So, Dr. Neha, shall we begin? I think some people have joined and more will join us.
Yeah, no problem. I can start.
So, a very good afternoon to everyone. On behalf of BLK Center for Child Health and IAP Central Delhi, I, Dr. Swati, welcome you all to this TELE-PEDS webinar. And we know that hearing is very crucial for a development of a child, particularly a young child. And a detection of hearing loss may be very difficult in such young patient, and it's very crucial for timely intervention. So let's hear from the experts what to do and how to approach. And to chair the session, we have with us Dr. A.V Ramesh, is Director ENT and Cochlear Implant at BLK-Max Super Speciality Hospital. Welcome, sir. And Dr. Vivek Choudhary, he is Senior Consultant Neonatology at Apollo Cradle Hospital, New Delhi. So over to the chairpersons. I request them to kindly introduce our speaker for today. Dr. Ramesh, sir, can you hear me?
Yes, I can hear you.
Thank you, sir. Over to you, sir.
As you rightly said, hearing loss in children is a kind of an emergency for the simple reason that if it is not corrected in time, you can lose the hearing for life. And if you intervene in time, you can do a great help to the child, and he becomes a asset to the society. I'm sure Dr. Neha will be speaking about this in greater detail, and she has a lot of experience in dealing with such children, and it will be quite enlightening for all of us to hear her speak. Thank you. Dr. Neha, please.
Thank you, sir. I think more than me, we will get a lot of insights and sir's experience will throw a lot of knowledge to all of us during the talk because he has tremendous experience. So we look forward to your comments and your sharing your experience too, sir. So if everybody has joined, I will start my talk now. So. Hearing loss, I think we all know is a very important. Hearing is, as we all know, is a very important part of our development. We hear speech, we learn words, we appreciate sounds, music. I think we can appreciate the emotions, and we can express emotions only because we can hear. So as when a child is born and he's able to hear normally, the development of all these things can happen normally. So we all know it is very important, and there is no need to stress on it. But the important thing which needs to be stressed on is, why are we calling this a neurodevelopmental emergency? Why should we treat it early? Why should we detect it early and treat it as early as possible? We can always wait. We can always wait for some time and then give the child some hearing, and then the development can happen later on too. But that's not the case. And that's the reason I'm talking to you today. So we should know what to do, how early to do, and when is the right time to intervene, or send such a child to an expert who will who will treat the hearing loss. So these are some of the figures. So an estimated of about 400,000 children today under the age of 4 years have severe to profound hearing loss. And additionally, 100,000 children are born every year with severe to profound hearing loss. So out of these, 30 per 10,000 children might have congenital hearing loss. And a significant hearing loss is seen in children who are kept in the neonatal ICU too. So these are some of the figures we all know. And when the child is born and is developing hearing, the first 6 months are very crucial when they hear speech and they start developing the language. And most of the children develop majority of their speech or learn a lot of things in the first 2 to 3 years of their lives. So if they are deprived of hearing, the development of this language gets delayed. And if not treated or corrected, it can hamper the speech for life. So, so this is a critical age when children should never have a hearing loss, or it should not be left untreated. So why is that? Why do we need to treat this early or intervene earlier to know that the child is suffering from hearing loss so that we can treat it early? For this, we should know how the auditory system develops. And so there is something called neuroplasticity, as we all know. So the auditory system does not mature without any stimulation. Only when the stimulation of the auditory cortex happens through hearing, it develops, it matures, the neural synapses increase in numbers. If it does not receive any stimulation, it tends to die. These neurons tend to die off and they do not mature. And this is one of the major reasons why we need to catch these children with hearing loss faster and treat them as early as possible. So here, when the signal reaches the auditory cortex, it matures. If the auditory cortex does not receive any stimulation, the visual pathway takes over, and the auditory cortex keeps on disintegrating. It does not mature. So either you use your auditory system, auditory cortex, or you tend to lose it for life. So as we can see from this slide, at birth, there are a few synaptic neurons. And as the child grows and reaches up to 2 years of age, you can see maximum connections being formed. So after 2 years, if there is no stimulation, these tend to degenerate and they die. So that is why the first 2 years are the most crucial, and you need to give these children hearing the first 2 years of their life. So this is a small video.
A child's experiences during the earliest years of life have a lasting impact on the architecture of the developing brain. Genes provide the basic blueprint, but experiences shape the process that determines whether a child's brain will provide a strong or weak foundation for all future learning, behavior, and health. During this important period of brain development, billions of brain cells called neurons send electrical signals to communicate with each other. These connections form circuits that become the basic foundation of brain architecture. Circuits and connections proliferate at a rapid pace and are reinforced through repeated use. Our experiences and environment dictate which circuits and connections get more use. Connections that are used more grow stronger and more permanent. Meanwhile, connections that are used less fade away through a normal process called pruning. Well-used circuits create lightning-fast pathways for neural signals to travel across regions of the brain. Simple circuits form first, providing a foundation for more complex circuits to build on later.
So that's the reason children learn simple words and then they move on to complex words and sentences. So these children who have a hearing loss, their normal childhood and adulthood is impacted. And how does that happen? So we all have seen children come up to our OPDs where we suspect hearing loss. There are different behaviors which we commonly see. Some of the children are really shy. They are totally secluded. They will not talk to anybody because their whole world is without any sound or without any speech. Many children are sad and angry. They usually misbehave. They are hyperactive. So they can be the two extremes because they are not hearing anything. So how does this hearing loss impact these children? The listening and communication skills can be affected. Speech and language, like we just discussed. Cognition may become a problem. These children are not taken up in normal schools, especially children with severe to profound hearing loss. So they do not receive good education, and ultimately they cannot be employed in good jobs. They become socially isolated and are usually lonely. they suffer from mental health disorders. And of course, there is a big category of stigma, especially in our country. So hearing loss, it affects relationships, it withdraws these children and they become secluded from the society. It impacts their communication skills with their loved ones and reduce job prospects when they grow up. So what can we do and what should we do? The most important thing is to realize that whatever needs to be done, it needs to be done right now. We start from screening, investigating, and treating as early as possible. So the recommended guidelines include the WHO's 136 principle, which has now become 123. Most of the countries follow this 136 principle. All children need to be screened at birth, which is done in majority of the hospitals and bigger centers and bigger cities. So if these children pass the OAE, which is usually done as a screening test, and they do not have any risk factors, they are not monitored. If these children have any risk factors, they should be kept under monitoring. Children who fail the OAE, the screening is done again. The OAE is done again at the end of 1 month. Children who fail the OAE again, then a diagnostic BERA needs to be done within 3 months of age. If that shows any kind of hearing loss, intervention should be done within 6 months of age. So like I just said, this has become 1, 2, 3, and in majority of many countries, they say that treatment should be done within 3 months. So this slide again summates the same thing, that screening should be done within 1 month, and all high-risk children should be screened as well as investigated, or a diagnostic test should be done, especially in children who have been kept in the NICU. Common risk factors, as we all know, include a family history of sensory neural hearing impairment, mothers with TORCH group of infections, craniofacial anomalies, low birth weight, hyperbilirubinemia, ototoxic, any history of receiving ototoxic medication, children who've had bacterial meningitis. So this I would want to stress on, that children who have had meningitis, the hearing loss, if detected, should be treated as early as possible, because these children, these cochleas can undergo labyrinthitis ossificans, and these children should be treated before the ossification happens. Next is children who've had low APGAR scores, who require mechanical ventilation, or any other associated syndromes. So screening in India and universally is done with OAE, and which is done at birth and repeated at 1 month if it fails. And ABR is the gold standard of treatment for diagnosis of any hearing impairment in children. This is a tabulated form of what I just mentioned, that once the first screen is done, if it passes and there is no risk factor, there is no concern there. If there is a risk factor, this child should be monitored. If the test result shows refer, and the second screen, if it passes, then there is no problem at all. But if it fails again, then a diagnostic BERA needs to be done. So these are some of the ways records are kept. This is a Swish result, and this is a hearing checklist which is used by many countries to see the development of the child in response to hearing. So some of the causes of hearing loss I've just mentioned here, which I don't think I will go too much into detail. We all know that it could be conductive hearing loss, cochlear, retrocochlear hearing loss, and hearing loss associated with congenital malformations. So this is a study, a longitudinal outcome of children with hearing impairment 2020 study, which took approximately 468 children with hearing loss born in Australia between 2002 and 2007. And this compares the result of children who were intervened early as compared to where intervention was done during the later years of life, intervention within 6 months and after 6 months. So all the children where either a hearing aid was fitted or a cochlear implant was done, basically a hearing loss was treated, did much better, developed speech much better, and than children who were treated later in their life. So how does this early intervention help these children? They get better speech perception in quiet and noisy environments. Their language development becomes much better. They read and write better. They obviously get educated, develop social skills. They have better quality of life, and they are psychosocially better than children who do not receive any treatment. So the most important thing here to know is that children who have been treated within 6 months, especially within 1 year of age, develop better speech than children who are treated later in their life. So if you compare a child who has been intervened or treated for hearing loss at an early age, before 1 year, the results of speech will be much different than a child who probably was implanted or treated at 5 years of age. And even the result would even be worse in a child who's treated at 7 years of age. So these are the common causes we all know: sensory, neural, conductive, and mixed hearing loss. So the grades of hearing range from mild, moderate, severe, and profound. Usually till moderate hearing loss, hearing aids will be beneficial. After this, because the hearing loss is much more, and the gain required is much more for a child to be able to understand speech and to be able to hear. Usually, the children will not benefit with hearing aids. Their cochlear implant will be beneficial. So the types of intervention starts with hearing aids. We have cochlear implantation, we have auditory rehabilitation, and I'm going to talk a little bit about the BAHA implant also. So the treatment options, again, it starts with hearing aids, cochlear implants, and bone conduction implant systems. So how would a hearing aid be different than a cochlear implant? Hearing aids amplify the sound, and they send them through the middle ear, outer, middle, and the inner ear, via the auditory nerve into the brain, whereas a cochlear implant, it bypasses the middle ear structures and the hair cells and directly stimulates the nerve. So hearing aids utilize residual hearing, and cochlear implants generally do not require residual hearing, but these days studies have indicated that children who have a little bit of residual hearing, they tend to do much better when an implant is done than children without any residual hearing. Coming to the candidacy, we all get confused when a cochlear implant needs to be done. Can it be done in all kind of hearing loss, all degrees of hearing loss, or when can it be done? Cochlear implant is usually done in children and adults who suffer from moderately severe to profound hearing loss, where hearing aids are not benefiting the child, and especially with this kind of a loss where the high frequency loss is much more, and more than moderate hearing loss, these children and adults will require a cochlear implantation, especially in children where a aided audiogram or speech discrimination score is less than 50%. These children will benefit better with cochlear implants than with hearing aids. So coming to these indications, how these indications for cochlear implantations have changed over these years. The cochlear implantation was started initially in adults. Unilateral implant was done in adults with bilateral profound hearing loss. It moved to children where implantation was done unilaterally for bilateral profound sensory neural hearing loss. Then it moved to implanting children with disabilities in 1 year. Then again, the indications increase and children are now implanted bilaterally. We are doing bilateral cochlear implants in most children in the same sitting, wherever it can be done and it can be afforded. And now implanting recipients, the indications have increased where we can implant recipients even with the residual hearing. Like I just said, children and adults who have a little bit of residual hearing tend to do much better. So this is the current change of indications from the past to the present. So the first implant, which I'm going to just brush through, is the bone conduction implant system, which is called the BAHA. Now let's see how it works.
How the cochlear BAHA attract system works. The BAHA attract system uses a magnetic connection to attach the sound processor to the implant. The sound processor picks up sound vibrations from the environment. The sound processor passes the sound vibrations to the attached external magnet that attracts to the internal magnet. The sound vibrations are transferred through the magnetic attachment to the small titanium implant inserted in the bone behind the ear. The sound vibrations are then sent directly through the bone to the inner ear, or cochlea, where they are converted into electrical impulses by tiny hair cells inside the cochlea. These impulses travel to the brain.
The BAHA can be done in children who have microtia, oral atresia, in children and adults who have chronic otitis media, who have had multiple surgeries and require hearing amplification, children with syndromes, and in congenital unilateral sensory neural hearing loss. So initially, in the younger years, we wait until the child's skull thickness becomes approximately 2.5 millimeters. So usually a BAHA implant can be done after 5 years of age. Before that, we have the soft band and the BAHA sound arc, which can be used. So this is what it looks like. And this is one of our patients where we had done BAHA. So this is the processor which you have to wear externally. So coming to our cochlear implant. So this is an audiogram which shows, we all can see the speech banana here. All children where the hearing loss is beyond the speech banana might require hearing loss, especially beyond this level, beyond the 70 decibel level, severe to profound hearing loss. These children will require a hearing cochlear implant. Below this, if the child is not benefiting with a hearing aid, especially with a high frequency hearing loss, then these children will require a cochlear implant. So we have transformed from a very big incision in the early 80s to a very small incision now, and big processors to now a wireless processor. Candidacy, which is the ideal age. The ideal age is anytime after 6 months. In some countries, it is even being done earlier than that. So 6 months is the ideal age when the child can be implanted. And these children who are implanted early, below 1 year of age or at 1 year of age, they develop normally. They develop normal speech. As you go beyond, especially after 5 years of age, the speech development is not good. So this is the ideal age. Till 5 is the ideal age where you can implant. The earlier, the better. Beyond 5 years, the result will not be as good as children who are implanted at an early age in their life. So this is how the implant looks like. This is the internal component of the implant, which we surgically implant under the skin. And this is the electrode, which goes inside the cochlea. And this is the ground electrode. So there are two kinds of processors, external processors. One is the wireless one and the other is the wired one. They're different models. So how does it work? Let's quickly play this.
Is designed to mimic the functions of the human ear. Sound travels to your ear and the sound processor, which sits behind the ear. The microphones on the sound processor pick up sounds, and the processor converts them into digital information. This information is transferred through the coil to the implant just under the skin. The implant sends digital sound signals down the electrode into the cochlea. The hearing nerve fibers in the cochlea pick up the signals and send them to the brain.
So this is how it looks like. I will just show you an X-ray image also, the internal implant inside the cochlea and the processor outside. So there are very few contraindications where there are congenital malformations, especially when the cochlea is absent. Deafness due to lesion in the acoustic nerve, active middle infections, tympanic membrane perforations. We usually seal the perforation and then do the implant in the next sitting. Where there is severe mental retardation or organic brain dysfunctions. So at our center, we have a team approach. We have a cochlear implant team, which includes our pediatricians here, the ENT team, our audiologist, the child psychologist, an implant coordinator, and of course we try to see the development of the child. So the children who are close by, we keep a track of how they are doing, especially even when the children are outside. We get a lot of patients from international countries. We keep a connect with them and know how they're doing later. So how do we work up these children? Once we know that the child is suffering from a hearing loss, we examine the child. A value of tests like PERA, OAE, ASSR, and impedance, all four are done in all these children. A trial is given with the hearing aid. If the hearing loss is mild, moderate, even moderately severe, we give a trial and see the speech discrimination score. Where we are planning for an implant, we do a HRCT temporal bone and a MRI to see whether all the anatomical structures are normal or not. Our pediatric team here takes care of all these children. They vaccinate them. All these children are vaccinated. We examine them thoroughly for other anomalies. Our child psychologist does an IQ assessment and rules out any other problems like autism or mental retardation. The very important thing when we are doing implants is to know whether we should do unilateral or bilateral. If the parents can afford an implant, then I think bilateral, everybody will agree, Dr. Ramesh will agree, a bilateral implant should be done as early as possible. If there is no possibility of doing a bilateral implant, then a unilateral implantation should be done as early as possible, which can be followed later. The other year can be followed later whenever it is possible for the parents. So I'll just show you a and the good cortical mastoidectomy is done, and we through the facial recess. As you can see here, we are drilling the implant bed where the implant is going to be placed after making the pocket here. And this well is being made for the electrode to go down the mastoid cavity. And now, as you can see, we're going through the facial recess. There is facial nerve here, the nerve here, and the scientific here. This we will do into the middle. And once the middle is nicely exposed, we can see the random window. Either we do the random window insertion or we make the cochleostomy. Here you can see a cochleostomy is being made in the cochlea. And once the cochlea is open, the basal bone is open, we will introduce the implant. And just quickly play. So this is a contour electrode. So it takes the shape of the cochlea. There's a skeleton inside of this implant. we introduce it completely and we take the slit out and it goes in the shape of the cochlea. Just like that, we put inside, we will seal it. So this is again another clip which I will not play. So this is a straight electrode. This is not a contour or a curved electrode. And so after complete insertion, the implant is tested, the processor is connected with the software, and or the placement of all the electrodes is checked per operatively before the patient is closed, the sutures are closed and the patient is extubated. First post-operative day, we do an X-ray for all the children as well as adults. So this is a bilateral implant here, and you can see the electrodes nicely in place in both the cochlea. So I'm just going to play a few clips now before I finish my talk. So this, I think surgery is just a part, just the beginning of this process of cochlear implantation. The actual work and the journey begins after that. So this is the day the external processor is being put on this child. And different children will have different responses. Some children get scared, some children are happy, some children are startled. So we'll just get some responses initially. So he's giving sound signals to this child, and she's trying to figure out where the sound is coming from. This is the first time she's hearing some sound. So these small little things, and slowly and slowly these children get used to the sound and they develop speech. So you can see the expression of this child. He was so happy when he started hearing the sound. It is surprising for some children. He's being able to appreciate the sound, and he was really, really happy. I think that's me behind. So this is another naughty kid. I always show this. And I think his expression is priceless. He is thrilled, I think, to hear for the first time. So I'm just gonna. So after the switch on, the rehabilitation starts. The rehabilitationists and speech therapists have a major role in this. Parents have a major role in this because they need to give 2 to 7 therapy sessions and how these children are supposed to be taken care of. This is the training which is happening in children. So this girl was implanted, and her parents are actually doing the rehabilitation. Every time she hears a sound, she's supposed to. So she's getting trained here. So these are a few kids who have been implanted, and this is a little bit of journey over these years of this child. So from starting to learn speech, where she's learning, she came to this stage where. What is your name? My name is Nani. How old are you? And now this is a few months back.
तुम्हारा घर कहाँ पर है नारायणी? स्कूल का क्या नाम है तुम्हारे? नाम बताओ ना, ये भैया दीदी नाम थोड़ी ना होता है, नाम बताओ नाम.
She can now make a full conversation. So this girl, her name is Karima. Again, a journey from learning with her father.
Little car, shoes.
So these are the kids who could never hear her. And this is now a few months back.
Hi, teacher. This is
So these children have all learned how to speak, and what is generally said is that children who have profound hearing loss when cochlear implant is done, they're more likely to close the gap on language development than children who are just wearing hearing aids. So these are a few of our patients where we have done cochlear implantation and they're doing very well. So we are growing every day, and we hope that we can bring hearing to more and more children as early as possible. So I played this as a last clip. This is a clip where I created, and you cannot understand the language of this child because it's a different language. But you can always make out that this child is having a normal conversation with the mother. And it's really thrilling to know that these children are doing so well. And we can always help all these children who need early intervention by actually uh, screening them as early as possible, diagnosing them, and then treating them as early as possible. And my last slide is going to be this invitation to all of you. We are holding a small celebration day for all these children where we have done an implantation. So I invite all of you to please come and celebrate the journey of all these children on 4th of August at Siddharth, where we are doing a cochlear implantee connect. So all our children are going to be there who have been implanted over these years, and we will have a little program followed by lunch. Thank you.
Thank you, Dr. Neha, for enlightening us about the cochlear implant and the importance of hearing assessment. So maybe I'll request our chairpersons to give some comments.
First of all, thank you, BLK-Max Hospital in IAP Central Delhi for inviting me. It was indeed an elaborative talk, and it was so heartening to see so many smiling faces at the end of the presentation. I have few comments. This has been overemphasized or adequately emphasized that early identification and intervention remains the key to optimize outcomes. And we want to highlight that we also understand that there are certain conditions which we say almost maybe 50% of the hearing loss in children can be preventable. Like we still in the era of current good vaccination in last maybe 9 years, we had seen 2 congenital rubella syndrome with profound hearing loss. We still feel that these are some preventable causes of hearing losses. Plus, we understand that HIE or asphyxia still remains an important cause. Neonatal jaundice requiring exchange transfusion. Again, these are preventable causes of hearing loss, which we can see in children. I have 2 queries to Dr. Neha. One, I want to understand regarding auditory dyssynchrony, which we tend to see in a lot of patients of neonatal jaundice. And is cochlear implant or any form of hearing aid useful to such patients? One, you mentioned about unilateral and bilateral cochlear implant. So how do you select patients? Is bilateral cochlear implant is the universal go, or there are certain set of patients where we still can go for unilateral cochlear implant? And I have a third one. Do you give a trial of hearing aid to all patients before embarking on to cochlear implant?
Okay, so I will address one question at a time. So, okay, we'll start with hearing aid trial. So here, in a child who has no residual hearing or who's having a severe to profound hearing loss, those children will generally not have any response with the hearing aid. So we do not want a child to hear a sound. We want children to understand speech. So that will not happen just by amplification, even if there is a little bit of residual hearing. So where this hearing loss is moderate, up till moderately severe, we can give a trial. Beyond that, a hearing aids usually do not benefit. But yes, a trial can get us no harm. So a profound loss, usually we don't. But with a moderately severe, yes, you will give a trial to a child with a moderate hearing loss and see how the child. We will do a behavioral audiometry. We will do a speech discrimination score. We will see how the child is responding or to using a hearing aid. If that is not benefiting, then we go and do a cochlear implant. Otherwise, in a profound loss, usually hearing aids will not benefit. Uh, anything, sir, you want to ask on that?
Now this is now clear. Yeah, we understand that. Okay.
Yeah, so the second one is unilateral versus bilateral. So if a child is having bilateral hearing loss, bilateral cochlear implant should be done. The problem is that implants are not they are not inexpensive, they are expensive. So most of the times it comes down to the affordability issue. So we have to leave it with the parents. Advised or advisable is bilateral if there is bilateral hearing loss and severe to profound hearing loss. Suppose if a child is having a moderate hearing loss in one ear and a profound on the other one, then maybe you can give a hearing aid on one and do a cochlear implantation on the other. But with a bilateral severe to profound hearing loss, you will advise a bilateral cochlear implant because binaural hearing is much better. It gives you better sound localization, better speech discrimination, better appreciation of music, sound, quality of sound which you're hearing than a unilateral implant. So, I mean, anything here?
Just for my understanding, what would be the cost in India of a bilateral cochlear implant?
So these implants are, there are three major companies which make these implants. So they have different models, like we have models in our phone or any other gadget. So the basic implant in all these companies will be on an average around 6 lakh rupees, one implant. The most expensive is very expensive, more than 10 lakh.
And my third question would be auditory dyssynchrony.
So at auditory dyssynchrony, again, we try to give a trial with hearing aids in these children. And and when that is not benefiting, which usually doesn't, then cochlear implant is the only way we can give any kind of hearing to these children, because the response here is there is auditory dyssynchrony. That means the response in reaching your brain is variable. But the only any kind of signal reaching your brain becomes more effective if you are doing cochlear implantation. Again, these children are given a trial with hearing aids, and the ultimate thing or intervention or any kind of hearing betterment you can give these children is by cochlear implantation. So the results in these children, we sit with the parents, we explain to them that the result might not be as good as we expect in a child where there is no auditory dyssynchrony and no other problem. Here, the result might vary. So we have to counsel the parents before we advise them a cochlear implant.
So this was the basic point I wanted to understand, because since any dyssynchrony, they take multiple opinions, because we understand the auditory nerve here is damaged. By doing a cochlear implant, you may not get a very good result.
So here, the parents will come and tell you that sometimes the child hears and sometimes I feel the child is not hearing.
Hearing loss in auditory synchrony can vary from mild hearing loss to severe to profound hearing loss.
Yes.
Based on the kind of hearing loss that the child is having, you can prescribe a hearing aid or a cochlear implant. If the hearing loss is moderate, maybe a hearing aid will work. If the hearing loss is severe to profound, he would benefit with a cochlear implant. The other thing that a cochlear implant does in such children is the dyssynchrony that is there. The way the electrical impulses pass through the cochlear nerve going to the brain, they get regulated nicely by a cochlear implant. So that is the advantage of a cochlear implant over a hearing aid. The dyssynchrony gets corrected by an implant. If you leave it alone, probably the child won't do well. But yes, hearing aid trial, adequate hearing aid trial is a good option before trying out, before going for a cochlear implant.
Thank you. Thank you so much, sir.
And even with the cochlear implant, Dr. Ramesh, I think you will agree that, the result, you have to counsel them that it might not, the child would benefit, but if in a normal child we say that the result is going to be exceptionally good, here you will counsel them for not that not have their expectations so great, but yes, they will do much better than not doing anything at all.
See, cochlear implant is a replacement for the cochlea.
Yeah.
So if you have a nerve disorder, a nerve dysynchrony, so the effectiveness of cochlear implant is limited. But in the absence of anything else, the
Yeah.
current standard of care would suggest that the cochlear implant will help. But yes, there are limitations. So we need to convey it appropriately to the parents.
Dr. Neha, I would like to ask a simple question. What instructions do you give regarding the maintenance of the external device and to the
There are
parent?
many things, there are nowadays we have chargeable devices. So, there are many things. How, first of all, we teach them how to do care and maintenance. Secondly, some implants, parents have a lot of questions that my child wants to swim and how do we charge it? How do we replace the batteries? So we sit with them and we give them all details. So there are sleeves which can be worn on the external processor and the child can go into the pool, and there are the new device can be there are implants which can be which do not get uh, you know they can be worn underwater also, the newer ones in one of the companies. And so multiple things need to be told to them, that especially while taking an MRI. So some implants are 3 Tesla compatible. Some implants you have to take care, the external processor and the internal implant, there is a magnet. That is how it sticks to the internal implant. So we have to give them every detail about what should be done, what should not be done, whether MRI can be done, how it should be done, and how to charge the equipment, how to clean it. Then we give them details of wherever they are, of implant help centers. And of course, they are connected with us all the time. So, I mean, we at our center have a group on WhatsApp where all these parents are connected to us. And anytime anybody is having a problem, then we try to solve it. Sometimes wherever the nearest company is, their company center is, we refer them there and then it's taken care of.
So what kind of common problems do you encounter in your clinical
There
practice
are
after the
people
cochlear implant?
who have broken the external processor also. So we have received that also. Then, simple things like they might need a mapping again. So you need to, do a mapping of the implant with the audiologist, and so that needs to be done yearly or 6 monthly to see whether some correction needs to be done. And the charging equipment, or even the processor, sometimes there is a wiring issue or something like that. Otherwise, these implants run throughout their lives. Small minor issues which you see in any electrical device, any electrical device, yes.
Okay, yeah, that's all from my side.
And do they require any revision also? Like in pacemaker, we say the life is 10 years, 5 years, 15 years. Do cochlear implants require a revision after certain years of age?
No, sir. The internal implant can run throughout the life. So the external implant, they are making implants in such a way that the external implant, if they, newer models keep coming, so the internal implant is compatible with whatever new external processors keep coming in. So if they want to change it as the years go by, and it will be compatible with the internal one. But usually, if there is no device failure, if there is no infection, if there is no meningitis, if there is no breakage of the implant, then they don't usually need any explantation.
Nice to know. because for all artificial implants there is a lifespan, but this
Yes,
is for the life expectancy.
The company gives a warranty for 10 years,
10 years.
but the first implant that I did in 2000 still runs. So 24 years, the
Yeah.
internal implant still continues.
Yeah.
The external processor undergoes a few upgrades, and over a period of time, the technology improves, so they keep changing that external part. The internal part often doesn't require any change.
That's good to
Here,
know.
yeah, the one comment that I would like to make, most of our audience are pediatricians. So identifying children with hearing disabilities, but along with it, they have other learning disabilities. So which might, mimic like autism. This
Yeah.
can mimic hearing losses. So we need to have our levels of suspicion much higher, and to be able to pick up these children very early. So children with learning disabilities vis-a-vis hearing disabilities. This differentiation is important at probably the pediatrician level to select patients appropriately and refer to ENT. The second comment that I would like to make is every kind of a hearing loss, whatever be it, today there is a solution for it. There is an answer for it. Whether it be a hearing aid, whether be it a cochlear implant, whether it be a middle ear surgery, we have an implant or a surgery or a assistive device for all kinds of hearing aids. So no child or an adult with a hearing loss need to be told कि अब आपका कुछ नहीं हो सकता. So this is something that I would like to pass on to all of you, that we can do a lot for all kinds of hearing losses. So that is a good heartening sign.
Very rightly said, sir.
I think sir has summed up very nicely.
I agree with Dr. Ramesh that for every kind, from mild to moderate to conductive to sensory neural, we have all kinds of devices, implants, and we can treat them very effectively in today's time. And it is just that we should be aware and we should be open to, accepting those treatment options.
So, if we do not have any more questions, we have come towards the end of the session. First of all, thank you, Dr. Neha, for such an enlightening talk, and special thanks to our chairpersons for taking out their valuable time and for a wonderful discussion. Thank you for all the audience, and next month we will be back with another interesting topic in BLK television.
Thank you.
Thank you, everyone.
Thank you.
Thank you. Thank you.